So if you look at the number of the slides, there are how much? How many slides? 84 slides. Huh? But don't worry, huh? Not all of you. I will select the appropriate for you, inshallah. Because I prepared all this to cover almost 80% of ECG. 80%, because there is another part I will not cover also. And it is also not related to you, because this, I prepared all this material. I like to use it for multiple purposes. It can be used for year 3, can be used for medical students, can be used for postgraduate. So for you, I will give you the appropriate for you. Huh? Don't worry, because ECG is a tough subject, huh? But it is not tough. In fact, it is not tough. I like ECG, it's very, very beneficial, because I have a very good relation with ECG during my clinical practice. I saved, alhamdulillah, I saved the lives of many patients through this tool. So that's why I like ECG, yeah? And hopefully also you like it. So the first part, inshallah, please make the session is interactive. You are mature enough now. I remember you, year 1, just you are looking at me. But now you are mature. So I think now you can be an interactive. It is an interactive session, just a discussion, discussion between us. Don't let me, I'm just, it is one way, I need 2 ways. So in the first part, I will make a review for you regarding the basics to understand. Otherwise, if you don't have the basics, difficult to understand. The second thing, I will give you the guide how to read the ECG data and how to express your finding. I discussed already with Dr. Fadila. She is the coordinator of this course. Dr. Fadila, she is the coordinator, and I discussed with her regarding how your exam usually, the examiners, how they ask you about ECG, how it comes in the exam. For you, it is a very simple and very direct. Just what you need. When you're given the ECG paper, either it is a paper in your hand or they may display on the screen. Okay? I'm not sure. But at the time, if you look at the ECG paper, you have to follow the guide which I will give you. Very simple guide and very direct. So don't miss the basics. At least, please, at least you should be able to know heart rate, how much for this. This is the basic. Second, is it regular rhythm or not regular? This is the second thing. Then go to the next 3 steps. But please, don't miss heart rate and the rhythm. At least you have to say to the examiner, the heart rate of this patient is 64 beats per minute, and it looks regular. Looks like as a regular. At least, don't be silent. Look at the ECG paper and you'll be shocked. So, inshallah, we will start the. So now, this is the medical significance of the ECG. This is the medical significance of the ECG. Usually, patients come to the hospital complaining of one of the cardinal symptoms of the cardiovascular system. the cardinal symptoms of the cardiovascular diseases. Number one, the most serious, alarming one, chest pain. Okay? Or the patient may come to the hospital complaining of palpitation. What's palpitation? It is a palpitation. What? Naqib. Okay, it is a heart rate, but the patient cannot come to you, I have increased heart rate usually. Not chest tightness. It is the awareness. The patient is aware of heart beating. He is aware. He is feeling that his heart. Now, are you aware of your heart beating? As if your heart is silent. Huh? But when you are aware that your heart is beating, this is palpitation. Palpitation. Okay? So the patient may come to you with palpitation. Oh, I'm feeling my heart is beating very fast, like this. Huh? So this is the second. So chest pain, palpitation, or sometimes the patient come to you with dyspnea. Dyspnea, now Naqib, he said chest tightness. Huh? It is not like chest tightness, but it is dyspnea. Dyspnea can be a symptom of cardiovascular and a symptom of respiratory. Okay, so the arrhythmia, abnormal way of heart beating, can be presented as dyspnea. Okay, yeah? So because of this, you have to do immediately the ECG. The ECG, inshallah, will tell you what's the problem. Now, so why I'm starting with this introduction? Because some of the examiner may be interested to ask you this. What is the significance of ECG? He will not ask you calculate the heart rate, identify any abnormality. No, he may start from this level. What is the significance of ECG? Why we are doing ECG in the hospital? You have to answer like this. Understand? Are you okay? Yes. Okay. Okay, yeah, so like this, huh? This may come with, complaining group. Then you have to do this. ECG, this is the monitor recording. Then you will get the result, start reading the result, identifying the problem, solving the problem of the patient, and giving the treatment. Okay? This is the scenario. Now we have completed. Done, huh? Okay. For the revision, please, you have to remember this. Your heart is doing like this now. This is the mechanical function of the heart. So this is a mechanical part. There is a contraction, relaxation, diastole, systole in both atria and ventricles. This function because of what? This is because of this system. Okay. So this is the mechanical, and this is the generator of this mechanical function. Okay? Now this system is very important, and the function of this system recorded as ECG. You have to know the structure of this electrical conduction system of the heart. Don't miss, please, these basics. What is the structure of the electrical conduction system of the heart? You have to mention. You start from this one. What's this? Full name? Excellent. Then we have. Okay. Between SA node and AV node, there is internodal pathways, and between the right atrium, which is the location where the SA node and AV node are located, the left atrium, what happened to the left atrium? How the left atrium is connected with this electrical activity through another pathway called as, or the name of the scientist Bachmann. This is the scientist, the physiologist who discovered Bachmann. No problem. Just you have to know this interatria. Okay, interatria. Okay, Naqib? Are you okay? Yeah? Are you happy? If you're happy, I will be happy. And also Ibn Sina, if you're happy, also. Okay, so now this is the electrical system and the electrical conduction system, or the conduction system of the heart. After AV node, we have what? Bundle of Hess. So this bundle will cross from the atria to the interventricular septum, and in the interventricular septum, it will divide into right branch and left branch. It terminates as Purkinje fibers. So this is the structure of the conduction system of the heart. It's a node, AV node, bundle of Hess, branches of bundle of Hess, Purkinje fibers. Done? Okay. Now, by this time, I'm sure you know, all these are the details for you. By this time, I'm sure you know the flow of this electrical activity. Why I'm saying this? Because you will see this on the ECG. So, the flow, the pacemaker of the heart, the generator of the first signal of this electrical activity is, that's why it is called as pacemaker of the heart. Pacemaker, this is the pacer. Look at me. This is the pacing. Pacing, the map of my walking, how I am walking. This map, step by step. So, the pacemaker means the generator or the source of the map of the heart activity. This one will set the activity of the heart. All the activity depends on this one. Okay? This is the manager. Okay, so now when SA node generates the signals, it will be conducted through the internodal as well as the interatrial pathway. So both atria will be depolarized. And once the atria is depolarized, following its depolarization, it will contract, produce the atrial systole. Then all these signals which depolarizes the atria will converge, will merge at AV node. At AV node, it will stop for a while. This is called as AV nodal delay. Okay? Then, after this delay, for a while, I will give the detail. The signal will cross from this chamber to this chamber through the bundle of Hess, depolarizing the ventricles. Then the ventricles will contract and produce the ventricular systole. Okay, all these are basics. Okay. Now this electrical activity, starting from SA node atrial depolarization and this delay also, then conduction through the ventricles, all this recorded as ECG. And all these activities will be reported on the graph, 1 to 1. Nothing missed. Okay? But keep in mind, ECG is not recording the electrical activity of each singular muscle. It is recording the total electrical activity. Yeah? All electrical activity at the atria will be recorded as P wave. Okay? And all the ventricular activity, all this electrical activity will be recorded as QRS. So don't think because it may come a true and false, some examiner they may be interested to ask us such questions. So they may say that ECG is the record of the actual, see this word, the actual cardiac muscle activity. It is wrong. It is the record of the total cardiac electrical activity. Understand? Now, you have also to know this, the rate. When SA node is normally functioning, the rate will be 70 to 80 beats per minute. If A node is functioning and SA node is not, the rate will be 40 to 60. If those two not functioning and the bundle of Hess or Purkinje fibers they are functioning, the rate will be 20 to 40. This is very important. If you look at the ECG paper and you see and you find the rate below 40, at that time you have to say that SA node, AV node not functioning. Okay, this is the importance of this basic physiology, to understand now the ECG. But when you asked about what is the normal heart rate in the clinical exam, what is the normal heart rate? 60 to 100. Yes, 60 to 100. But I am mentioning 70 to 80. Why? Any answer? Please, I said in the beginning, please make it interactive, otherwise I will go out. I will see you. Please, do some interactions. So why? The normal heart rate is 60 to 100, but the pacemaker, the source of the heart rate, 70 to 80. Answer. Because this is the heart rate at rest for the adult, and SA node at that time is under the vagal inhibition. It is not allowed for the full activity. If you omit or remove the vagal supply to the heart, this SA node will fire up to 100. But it is tightened by the vagal supply. So vagal supply continuously, it is called vagal tone. Vagal comes from vagus. Do you remember vagus nerve? Okay. So this is the vagal supply making a continuous suppression of SA node. Imagine if you are now at rest and your heart rate is 100. You will be distressed, But this heart rate is allowed to be 100 when you do some exercise. When you saw me, your heart, there is a problem. Dr. Hamad is there, so there is a problem. He will teach us some headache. So, as any stressful situation, the vagal supply will inhibit it, sympathetic supply will go up, and the SA node allowed normally to go up to 100. Understand? So when you ask it in the exam, what is the normal heart rate? You will say 60 to 100. If you saw the ECG and calculate the heart rate and found it 95 beats per minute, you have to say what? Normal or abnormal? Normal. Full confident. Don't be hesitated. It is fully confident. Below 100, it is normal. It is not tachycardia. If it is more than 100, you have to say what? Tachycardia. Below 60? 60? Yes. Be clear, I like to be clear like this. 60, normal. 100, normal. Don't say 100. Oh, it is touching 101. No, 100, normal. Okay, Full confidence. This is very important for the clinical exam. If the examiner found you You are not confident, oh, he will play with you. You will be in trouble, huh? Confident. Okay? So this is all the details for you. Inshallah, if you like to read. Just now, this is a revision for the ECG paper. You have to understand this paper very well. As a reminder, the ECG paper, it has what? Large boxes and small boxes. Each large box containing small boxes. Okay? What is the significance of this? Through these boxes, we can calculate two things: the time, then the voltage. Why we need to know the time? Because you cannot say P wave is normal, QRS is normal, PR interval is normal, except when you know the time. Otherwise, you cannot say. So why this horizontal tell you the time? Always, please focus on the time. Voltage, you need it in maybe two situations, but the time is very critical for you. Heart rate is the time. You have to look at this horizontal line. Rhythm, you have to look at this. PR interval, you have to look at this. QRS, you have to, okay, yeah? Understand? So it is very important to focus on the time, which is the horizontal. Okay, the large box is equal to 0.4 second. And if you like to go to the small boxes, it is the large box is 0.2. And the small boxes are 0.04. Okay, and there are 5 in each large box. So either you express your finding using the large box or the large square, or use the small square. Okay, don't confuse yourself. Decide how you will look at the ECG. Okay, for me, always I am playing no problem between the large and small, but I like to use the small, more precise. So in my mind, small box 0.04 second. Okay. Okay, this is the second important point to know about the ECG paper. Okay. Now, if you look at the ECG paper, there are positive waves. Positive means above the isoelectric line. This line is called isoelectric line. Okay, this is the horizontal line. This line. Isoelectric line. Okay. Any wave above, it is called positive deflection. Any wave below, it is called negative deflection. Why? Each word I am saying, it has it's significant, clinical significant. Huh? Why? Because if you find the P wave negative, this is abnormal. Immediately, if you look P wave below the iso, this is abnormal ECG. Understand? If you find the T wave like this, it is abnormal. There is something wrong with this patient. Okay? So this is how you see the waves now. So we have positive waves and we have the negative waves. Q and S, usually they are negative waves. Others, P, R, and T are positive, always positive, except in one lead of the ECG, 12 leads, except in one. Okay, I will show you inshallah. Now, the second thing, so now the waves, when you look at the paper, when you're given the paper of the ECG, you have immediately to look at the waves. P, Q, R, S, T. Positive, positive, positive. Okay. This is the second. Second thing, intervals. The intervals we have two, but one is important for you. PR interval. Beginning of P wave up to the beginning of QRS complex. Up to this line, no? Remember, beginning to the beginning, not beginning to the end. Beginning to the beginning. So beginning of the P wave up to the beginning of QRS means don't include Q. P wave not be counted. So you have to know this interval. Very, very important for you. QT interval, ignore it. I say this at the beginning. Huh? So there is something important for you now as a third year dental student. So waves and PR interval. Now this interval, you have to know the duration of this wave, of this interval. Huh? How much? 0.12 to 0.2. You have to know. Why? Because if this interval is prolonged, oh, there is abnormal rhythm. If it is prolonged, means now you can diagnose some finding. Huh? If it is normal, okay, you will be happy, and most likely, no abnormal. Most likely, because there is other things. Huh? Okay. The third for you, please, huh? Because as I mentioned, the slides, they are covering even the postgraduate. But for you now, when you given the paper, look at the waves, P, Q, R, S, T, which is positive, which is negative. Number one. Number two, pick up the PR interval. Number three, I will ask you a very good question. This is my way. If you go to sleep, I will ask you. Okay. So, waves, PR interval, and now look at this segment. ST segment. This is very important. So, three things for you. Very easy. Yeah? Very easy. Look at the waves, which is positive, which is negative. Number two, PR interval. Number three, ST segment. Ignore the remaining. ST segment, it is the horizontal isoelectric part of ECG graph extending from end of the S wave to the beginning of the T wave. This is the definition of this segment. It is called as segment. Okay. Now, if we like to connect this basics with the electrical activity of the heart. Okay? Now this P wave is produced due to what? Atrial? Don't say atrial systole. It is depolarization. Huh? Because there are two things. In the beginning I mentioned there is mechanical activity and there is electrical, right? So ECG is electrical. Don't say this is atrial systole or this is ventricular systole. No, it is not correct. It is not scientific. Even though some of the doctors they are mentioning this, but it is not scientific. This is the electrical activity. Why? Because on the actual time, after this recording, the atrial systole happening during this period. After the mechanical function is following the electrical excitation. So don't say P wave, atrial systole. No, it is in fact it is after that. It comes behind. Huh? After that. So now, if you are asked in the exam, P wave is indicating what? Atrial depolarization. What is the source of this P wave? SA node. Remember now, this is very practical and important for you. If the P wave shape is changing, this means it is not coming from SA node. This is the typical shape of SA. If the P wave coming from the SA node, it will be this in this shape. If there is any other source other than SA node, the P wave has a different shape. This is helping you also. So if you look at the P wave, you find it very beautiful, like this, normal, positive deflection, smooth, and followed by this complex. This means it is coming from SA node, definitely. Okay, now the second question for you. This segment, this short part, is due to what? What do you think? Huh? What? Delay, yes. So this is the delay which happening at the AV node. Okay. Some of the doctors they may ask, some. So this is now as I mentioned to you, from the ECG we can know everything. What's happening in the heart, you can see. After that, the signal will be conducted from the AV node to the bundle of His, to the ventricles. Ventricle will be depolarized. Depolarization of the ventricle will produce all this complex, QRS. So QRS is produced due to depolarization. Ventricular systole will be after that. Yeah? Then, now, T wave is produced due to repolarization, yes. And after that, the ventricle will relax. Okay, yeah? Now, what about this ST signal? Which is very important. Huh? I mentioned to you, you have to look to the waves, PR interval, ST segment. This is your level. You have to recognize all these three. Don't miss. Waves, PR interval, ST segment. Don't confuse yourself. Ignore everything in the ECG. So now ST segment is produced due to what? ST segment. So if you look, this is ventricular depolarization, right? And this is repolarization. So between depolarization and repolarization, it is the time where the ventricles cannot be stimulated. It is the time of a plateau. Can I have a marker? Do you have a marker? Okay. Just to show this is all these are the basic, huh? So if you look at the action potential of the ventricular muscle, the ventricles, huh? This is a depolarization, this is a rapid early repolarization, and this is called plateau. Okay? This is the plateau. This is plateau, time where the ventricles are still depolarized and cannot be stimulated. If there is any other signal coming to the ventricle will not respond. This plateau seen on the ECG as ST signal. Understand? Alhamdulillah. So for this, I think now almost the basics of the ECG will, I think they will be covered. Huh? I cannot cover everything, but you will find, inshallah, the detail in the slide. These are the details of the nodal delay. Okay, the total time of the delay at AV node. See here, the signal coming from the SA node, depolarizing the atria, then all they meet at the AV node. But from the SA node to AV node, it will take 0.3 seconds to arrive. At AV node, there is another delay of 0.9. Okay? So up to now, there is a 0.3, 0.9, so 0.12. This is a delay. This is very important. Why? To allow the ventricles to give time to the ventricles. Otherwise, if the signal from the atria immediately go to the ventricle, the atria and the ventricle will systole at the same time. And this will disturb the cardiac function. And this happens, also can be seen in the ECG. But for you, this is theoretical. Just I need you to know that AV nodal delay seen at the ECG as what? PR interval. All this PR interval is the atrioventricular conduction time, including the AV nodal delay. I will repeat. Don't be confused. See, if you count for the PR interval from the beginning of the B to the beginning of the Q, this is the PR interval. This means what? This is the time for the signal conduction from the atria up to the ventricles, including this part. And this part means AV nodal delay only, yeah? Understand? Understand? Is it clear? Okay, so we will proceed. Okay, now the recording. When you are given ECG paper, they are usually recording 12 leads. Okay, we have 6. I will go quickly. Yeah, 6 chest leads from V1 up to V6. Okay, and we have a limb leads, and we have the augmented leads. Augmented leads: AVR, AVL, AVF. Okay, so there are 3 categories of the ECG leads. We have the bipolar limb leads, 1, 2, 3. And we have the augmented or unipolar leads, AVR, AVL, and AVF. And we have chest leads, they are 6 in number from V1 up to V6. This is how they record the ECG, yeah? How we can see all the electrical activity of the heart from different angles. Okay. I need you to try to understand this, please. Huh? The leads, when you look at the ECG paper, you can identify if there is abnormality in which part of the heart. Is it in the anterior part of the heart? Is it in the inferior? Is it in the lateral part of the heart? Also, you can know this from the ECG. Very beneficial ECG. So you can also localize. This is important in one case, not in cases of tachycardia, in case of arrhythmia. It is important for you if you find myocardial infarction. If you find myocardial infarction, so ECG will inform you. ECG will not let you alone. He will inform you, this infarction is located in the anterior surface of the heart. This infarction is inferior wall of the heart. So do you like to take this information or leave it just to say myocardial infarction? You need to take that information, huh? Okay, very good. Now I am happy. So if you look at the, I will teach you different leads. They look at the heart from different angles, so we can know the abnormality of ischemia. Arrhythmia, nothing to do with this. Okay, so let's proceed. Now these are the chest leads. Now, please recognize this slide as important for you. This is the practical guide which I mentioned to you. We knew how you read now the ECG. Now I finished the basics. Now already I finished the basics. Do you have any questions regarding the basics? Any questions? Are you okay?
Yes.
Are you happy?
Yes.
Very happy?
Yes.
So now the practical approach. This is the most important for you. How you start. From which door you can enter to this paper. You have to follow this, please. Try to memorize this as if you are memorizing your name. Immediately, ECG, I have to calculate the rate. First, I have to find the rate. Even though the patient has myocardial infarction or ischemia, don't worry. I have to calculate the rate. Number 2, you have to look at the rhythm. Is it regular or not regular? This rate, is it regular or not regular? Yes, you calculate the rate, you find it 95. But is it regular or not regular? Then you have to determine the axis of the heart. Is there is right axis deviation or left axis deviation? Very simple, and I will guide you inshallah, no problem. Then look at the intervals. The interval will help you to confirm is there is arrhythmia or no. Okay? Then look for evidence of hypertrophy. We have right ventricular hypertrophy and we have left ventricular hypertrophy. Okay? Then look for evidence of infarction. Or I make it like you can edit this. I look for the evidence of myocardial ischemia. Yes, correct. Look for the evidence of acute coronary syndrome. No problem. Okay? So just I mentioned infarction. because it is very, in fact, a very strong word. It will make you alert. So this is the flow, how you look at the ECG paper. Don't confuse yourself, and don't be in hurry so you miss something. First thing, heart rate. Then, is this rate regular or not regular? This is the rhythm. When I say rhythm, you mean regular or not regular, this rate. Then, after that, axis. What about the axis of the heart? Is it right axis or left axis deviation? Then look at the PR interval. I mentioned intervals, but for you is PR interval. Huh? Only PR interval is enough, and more than enough. Then evidence of hypertrophy, then evidence of ischemia. Okay. If you find this so much for you, don't miss this. Rate, rhythm, infarction. Please, if you are crowded at the time of the exam or at the end of the year and you have many subjects to read, you cannot memorize, you have to drop some things. Please, keep this rate, rhythm, infarction. You should be able to identify this. Okay. I don't like the other examiners to say that the dental students, they are not good. This is very hurting for us. So that's why I'm giving this one to make you to stand. Okay. Don't underestimate yourself. Oh, this hospital, big hospital, and there are clinicians, and there are examiners, and we are not medical students. No, you are medical and full professional. We have a scholar with us. Okay. So don't underestimate yourself. I'm sure if you do like this, inshallah, you will be very excellent. So if you like to drop some things, keep rate, rhythm, look at this. Now I will review with you how to calculate the rate. Okay, I am sure you know how to calculate the heart rate. If you have, there are two ways to calculate. You are preferring which one? Divide by? Okay. And the second, you have to divide 1,500 by the number of small squares. Huh? Okay. But if the rhythm is irregular, so you have to go to this one. So if the previous one, this is if the is regular. So just you can count the large squares in between two consecutive R waves. Okay, and you proceed, no problem. But if these are and these are like this, 1, 2, 3, 4, 5, and you look at the next one, you find 1, 2, 3, 4, 5, 6. Oh, so it is not regular. Immediately count 30 large squares. Don't miss the time and don't be stuck or you find it is so difficult. No, not difficult. Just look at two. Look at two R waves. 1, 2, 3, 4, 5. The next 1, 2, 3, 4, 5. Okay, you can proceed now. If there is difference in the number, so to be in the safe side, count 1, 2, 3, 4 up to 30. Up to 30 large squares. Then count the number of R waves multiplied by 10. You will get the number of heart rate and you will be in the safe side. Understand this? I will repeat. If you are given an ECG and the rhythm is regular, means what from the beginning, you can know the rhythm. Look at the number of the large squares between the R waves. If you find the number is fixed between each R waves, this is 5, then R wave, 5, and R wave. This means it is regular. Huh? Most likely it is regular now. So you can use this formula. But if you find it is, for example, 5 large squares, then 6 or 7 between the next two. So this means it may be not regular, right? So what you do, immediately, don't waste the time. Count 30 large squares, okay? Mark by pen, your pen, up to 30. Count the number of R waves in those 30, multiply by 10. You will get the heart rate. And this is mentioned already in this slide. Understand? So now we settle with heart rate. So now almost through the exam, you put 33% of the marks. Heart rate. Very basic, very important. Clear with heart rate? Don't miss. Clear? I am feeling you are not satisfied. Are you okay with the heart rate?
Yes.
If there is anything not clear, inform me. Okay, huh? Okay. So now, what do you say to the examiner when you calculate the heart rate? You have to say something. Don't count and keep it with you. No. Express yourself to get the marks. Why you are doing all this work? Your marks should be recorded. So now immediately, when you calculate, this heart rate is, for example, it's 80 beats per minute. Expressed like this. Make the examiners very happy. And knowing you are scientific, telling that scientific terminology. This ECG showing that the heart rate is 80 beats per minute, not beep. Beats per minute, like this, huh? Why? First of all, this is the scientific talking, no abbreviation. Second thing, to use the time. Don't let the examiner having the time. Speak and make them delay a little bit. Otherwise, he will immediately strike you with the next question. So that's why this ECG is showing that you are using the time of the exam now. This ECG is showing that the heart rate is 80 beats per minute, which is normal. Okay? If you find it below 60, you mentioned this patient having bradycardia, more than that, tachycardia. So now you can approach diagnosis. Making normal, you are saying that this is normal heart rate, you are making diagnosis. So diagnosis not only disease. Some they are thinking like this, if you find a disease, I can make diagnosis. No, diagnosis normal. This is a diagnosis, and this is the best diagnosis, and the most difficult diagnosis, to say this is normal. Okay. Then the rhythm, okay? In the rhythm, I prepared many scenarios of rhythm for you, but I will select the most appropriate one for you again. Listen, I will give you a break now. Take a break, because I have 3 hours. Okay, take a break. You need 5 minutes, 7 minutes, 8 minutes? 8 minutes beat per minute? Take 7 minutes. Bismillah. Let's continue. Inshallah, I will give you another break after a while. So the second step is to find the rhythm. And the rhythm just you have to say regular or irregular. So this is the final. This is the final result. As the rate, count the rate, then you have to say the rate is like this, 85, whatever, beats per minute, and it is normal or bradycardia or tachycardia. Then when you work out the rhythm, you have to say regular or irregular, just one word. Now, the rhythm, how you look at the rhythm, we have two things in the heart. Either it is sinus rhythm or it is non-sinus rhythm. One of two. Sinus rhythm, when there is the following criteria. Okay, P wave. That's why I mentioned about P wave before. P wave, the normal sinus rhythm. P wave is upright, means positive deflection. Then PR interval is normal. And you know the PR interval, duration is 0.12 to 0.2. And each and every single P wave followed by QRS. You see the three criteria, straightforward. Sinus rhythm. Is a normal sinus rhythm. Normal sinus rhythm, it doesn't mean the rate is abnormal. So now the rate is already calculated. For example, you count the heart rate and you found it 120 beats per minute. When you go to the rhythm, you may find it normal sinus rhythm. There is no conflict, no problem. Rate is abnormal, but the rhythm is normal. Okay, yeah? Is it clear, this one? So if you go to the rhythm and you find it normal sinus rhythm, you found all these three criteria are normal, straightforward, say it is normal sinus rhythm. If the examiner says that, how the heart rate is 120, and it is normal, yes, it is normal sinus rhythm. Why? Because the P wave is normal, PR interval is normal, and each P wave followed by QRS, it is normal sinus rhythm. Okay? So, this is the, when you look at the ECG, look at this for example. Now, take this example. Apply now these three criteria. One more thing, one more practical clinical tip. When you look to the rhythm, go to the what's called the strip. Now we call it the strip ECG. Usually the leads they take them for short time. They may count or they may record 3 to 4 waves. Lead 1, lead 2, lead 3. Look at V1, short. This is a very short graph, right? So for you to look at the rhythm, always go to the strip rhythm. This one. Usually when they record, they take lead 2. Commonly, this is worldwide. They record lead 2 again. This is short segment, and lead 2 they record a very long strip. For the rhythm, look at this. For the rate, you can use this also. No problem. But for the rhythm, essentially to look at this. So now look at this and apply these three criteria. What do you think? Number 1, P wave. Where is the P wave? No P wave. So one criteria. Now, immediately, this is non-sinus rhythm. Okay? Even though there is what? QRS. Many QRS. But there is no P wave, no P wave, no normal P wave. Where is the P wave? There is QRS without P wave. So this is non-sinus rhythm. It is not sinus. Okay? This is how to apply these three criteria. Now, can you memorize these criteria? What are they? Each P wave followed by QRS. This is the third one. Okay. How we analyze. How we analyze. This is a case of atrial fibrillation. Very common. And some examiner, they like it, but inshallah for you, they will not bring this one. But it's very common case. Okay? This is atrial fibrillation. Okay, so this is the rhythm. How we analyze the rhythm now? Okay. The simple way, I'm always teaching like this. I give you something which should be in your hand. And I give more details. You catch as much as you can. Okay? But for the rhythm, as I mentioned before, the three things: rate, rhythm, and infarction. Don't miss. If you miss the axis, hypertrophy, okay. But don't miss the heart rate, regular or irregular rhythm, and there is evidence or there is no evidence of infarction. Don't miss these three. Now again, in the rhythm. In the rhythm, just please, sinus or not sinus. Don't miss this. Look at the P wave, the PR interval, and each P wave followed by QRS. Okay, sinus rhythm. If you cannot do the following, don't miss this one. Recognize the criteria of sinus rhythm. Understand me? Now, if you are more excellent, you can proceed like this. Step 1, for the rhythm, heart rate is calculated because the heart rate is part of the rhythm. Number 2, determine the regularity. Is it regular or irregular? Number 3, look at the P wave. Is it normal P wave or not normal P wave? See, in the criteria I mentioned, there is P wave. And each P wave followed by QRS. Now, there is certain criteria of normal P wave. This is more a little bit deep. Determine the PR interval. This is important for the rhythm. But in the criteria, I didn't mention PR interval, right? So this is more deeper for the student who like to get more and more marks and more details. Then, determine the QRS duration. Now see the detail, duration. Before the criteria, there is a QRS after P wave. So now you have two things in your, one in your right hand, the three criteria which indicate that sinus rhythm or not sinus rhythm. Don't miss this. This is the lowest level. And based on this, you can pass. But if you like to pass with the A plus, A minus, A plus, so go to this. In the rhythm, you have to express more about especially the PR interval and the duration of QRS. Understand? Okay. So this is how we analyze the rhythm. Now the regularity of the rhythm. Step number 2, because now number 1 is the rate already calculated. Now regularity. Is this rhythm regular or not regular? Just you make it easy. If you are given the paper of the ECG, please, your pen and your plain paper. Take plain paper, put the ECG paper on that plain paper and mark the R waves. Then look at the distance between them. If there is equidistance, same distance between your marks, it is regular. Direct and easy way for you. So look at this. So it is regular. Or if you find it is different, accordingly, it is irregular. Okay? So you can find it sinus, regular. Sinus, irregular. This is the result. Again, same I mentioned regarding the heart rate. Heart rate is abnormal, there is tachycardia, but the rhythm is sinus and normal sinus rhythm. Sometimes you find like this. Sinus, Regular, sometimes sinus, irregular. Yes, it can be sinus and irregular. So don't be confused that irregular means it is not sinus. It can be sinus and irregular. The final conclusion regarding this regularity, sinus regular, sinus irregular, can be. Okay, this is normal. All these are normal, just for discussion. Okay, so look at the distance. You can mark them by the pen. The interpretation, regular or irregular. Only one word. Okay. Step number 3, P wave. Look at the P wave. Okay, positive P wave. So it is positive, and this shape, dome shape. Sometimes you find P wave, it is not dome shape. Sometimes it is peaked like a tent. It is not normal. Sometimes it's like this, because we have another diseases, like this P wave. See, like this. So this P wave is not normal, because it is the normal is like this. From this we can know something. This is called P pulmonary. This indicates pulmonary hypertension. I mentioned even the valves. You know the heart valves? We can use ECG for the heart valves to know the diseases. But this is not for you. Just I am showing the significance of the ECG, how it is important. So now this is the P wave. Look at the P wave. P wave is normal. Okay. Do the P wave all look alike? Do the P waves occur at regular rate? If you find there is P wave not followed by QRS, you have to mention this. But now each P wave is followed by QRS, and the P wave occurring at regular time. Okay. So this is how to assess that we are in the rhythm. Is there one P wave before each QRS? Ask yourself these questions. So if you meet all these criteria, so it is a normal, sinus and regular. Normal, sinus and regular. See, when you finish the analysis of the ECG, you can give at the final, you can give a very beautiful statement at the end, including the rate, your comment on the rhythm, your comment on the axis of the heart, your comment on if there is evidence of any hypertrophy, your comment if there is any evidence of ischemia. Very beautiful sentence. If you give this to the examiner, he will be paralyzed. Okay? Okay. So normal P waves with one P wave for every QRS. This is your result. PR interval. We mentioned this, and you know the duration, right? Why I am saying this PR interval? Because if this interval is prolonged, there's another problem now. You will see later. So this is the normal, or by small. If you would like to remember by the small box, it is also another way. So it is the 3 to 5 small boxes. Look at the PR interval. Look at the small boxes, 3 to 5, normal. If you don't like to memorize the numbers, you can use this style also. Okay, so 0.12 seconds, normal PR interval. Now QRS duration. Again, QRS 1, 2, 3 small boxes. This is the normal. After more than any QRS, you will see some diseases. I present, inshallah, I will present this. So if you find any QRS complex more than 3 small squares, it is called wide QRS. Wide QRS, it is abnormal. Okay, so all this now we are 5. Now we have done 5 steps, only looking at the rhythm. Okay, only we are looking at them again. I will revise for you very quickly the steps again. Now this done. Okay, this slide is very important. See, so how you do the rate is calculated from step number 1. When you give in the paper, immediately the rate. then go to the rhythm. How you look at the rhythm? You have to apply all this. Okay? At the rhythm, if you like to go to the shortcut, look at the P wave, PR interval, each P wave followed by QRS. Done. Now the rhythm is analyzed. If you like to go more detailed, do this. Okay? And as I mentioned to you, you have to express your work that has been done. Don't do things and keep silent. Okay? Utilize the time and make the examiner to drop some questions. If you just when you speak, you will guide them. Believe me, because I'm examiner. I'm giving you some hints and some keys. So just when you speak, you can guide the examiner. And also when I was a student, I have done this many times. I guide the examiner toward the area which I am fit in that area. Try to shift, huh? Do this with me again. Huh? Okay. So now this is done with the rhythm. Okay. For the rhythm now, I suggest that the following, because the number of slides, many slides and many cases, I prepare many cases, different types of rhythm. I suggest to go to the axis, the evidence of hypertrophy, the evidence of ischemia. Then we go to the arrhythmias. Why? Because even the clinicians, they don't like arrhythmias. They don't like arrhythmia because little bit there is complications. But there are common cases which are straightforward. I will give to you. So, do you like to proceed with the arrhythmias? Then we reach at the end with ischemia. At that time, sure you are hypoglycemic, depleted. Everything is depleted. So, because the ischemia is very important for you, right? Now, read rhythm. I will go to the ischemia. Okay, yeah. Because you are still fresh, 50% fresh now. 50%. Not 40%. Okay? What happens? Or before the axis, I will go to the yes, evidence of refraction. This is very important. Then we will go to the axis, then go to the other. As I mentioned, now how you identify evidence of myocardial ischemia, or commonly the common case encountered in the hospital is myocardial infarction. Okay. It is a pathological condition of the heart due to the blockage, due to the block of the coronary blood supply of the heart, anterior, different branches of the heart. Can be the anterior descending, can be the circumflex artery, can be the posterior intervertebral descending, whatever the artery can be blocked. When blocked, it will lead to myocardial ischemia. The heart muscle, not enough blood supply, so we'll go to the ischemia, what's called ischemia. So look at the ECG, just now, now you finish with the heart rate and you analyze the rhythm, done. Go to the evidence of ischemia. These are the three important for you, as I mentioned. Our plan A, this is plan A. Plan A to pass, to be in the safe side. Rate, rhythm, ischemia. Immediately. Okay? So, for evidence of ischemia, remember that ECG can inform you about the evidence of ischemia in which part of the heart? Is it in the anterior part of the heart? Is it in the lateral part of the heart? Is it in the inferior wall of the heart? And these are the common sites of myocardial infarction. from the leads of the ECG, for the anterior part of the heart, you can find the changes in the chest leads V1 to V4. Chest leads, V1 to V4 can inform you about the status of the anterior part of the heart. But the lateral part of the heart, you can get some idea from the lead 1, AVL, and from V5 to V6. I will give you examples now. Don't worry, you will see examples. And you will be agree about this. So, lateral portion of the heart, you can V5, V6 plus AVL and lead 1. Inferior, which is very important. Mark this important in your note. Because if the examiner like to give you myocardial infarction, they will give the inferior one. Very straightforward, very direct, very clear. Because usually the examiner, they don't like to bring to you a question which is not clear. They will not give you ECG not clear for the evidence of myocardial infarction. They will give you very clear evidence of myocardial infarction ECG. From a distance, you can see the changes. So usually they bring the inferior. Inferior wall myocardial infarction usually in the ECG very clear. In which leads? Remember this. 2, 3, A, B, F. 3 leads which indicate infarction in the inferior wall of the heart. Lead 2, 3, A, B, F. Okay. What are the evidence now? How you know there is a myocardial infarction? Please remember ST segment. I mentioned in the beginning, ST segment. That's why I inform you about the waves. The interval you need to remember and know PR interval. For segments, we have more than this, but we have ST segment. For you, ST segment. ST segment, just you don't need to look at the duration. You need to look for elevation or depression. So this is the difference, So in case of PR interval, we are looking for what? Duration, right? But for ST segment, you are looking for elevation or depression. The normal ST segment is excellent. Okay. So now this is just, I will show you real cases of myocardial infarction. But this is a normal ST segment, and this is how the ST segment change in case of myocardial infarction. Okay. Look at this now. So this is the ECG leads. This is the ECG leads, V1 up to V6. If you look at V2, what is this? See the ST segment, it will disturb and distort the QRS complex completely. Don't think you will see the QRS complex, because the ST segment once shifted up, once elevated up, it will change the shape completely. So this is the ST segment. This is the ST segment. See? And it also affects the T wave. So this is the ST segment. ST segment up. ST segment and ST segment. See now the progression. It is very marked in which leads? V2, V3, V4. Very marked elevation, very clear ST segment. So when you see this, when you see ST segment elevation, immediately you have to mention what? There is evidence of myocardial infarction. Step 1. Step 2, location. Now, pass immediately with good mark. If you go to the location, you will be excellent. You will be like a physician, cardiologist. Because the cardiologist, yes, he will do like this. He will localize. But there is a next step. When he localizes, why I am localizing? When I localize the myocardial infarction, then I knew which branch of artery is blocked. then we have to manage that branch, either medically or by intervention. Okay, so now agree about these changes. Now, my question, can you localize the area? Here, most likely anterior. Very clear. Very good. Okay. So now the next thing I have to mention, T segment elevation. Just one small square up, significant. Imagine, just if the ST segment elevated only one small square, it is significant. It is not like other waves or PR interval. PR interval sometimes, if it is one small square beyond the normal, maybe not significant. But ST segment elevated one small square, it is very, very significant. The breast one small square, it is significant. Understand? Are you okay now? Okay, so we go. These are for you, theoretically. If you are asked, usually the examiner, if you say like this, there is a myocardial infarction, there is evidence of myocardial infarction, immediately, what are the causes of myocardial infarction? Or he like to, what you are seeing in the ECG, you see that there is ST segment elevation. He will mention what other causes of ST segment elevation. Okay, so these are the, I mentioned to you few, very, very few to remember. If you like to remember them. ST segment elevation. Causes number one, acute coronary syndrome. What's acute coronary syndrome? It is two. Either myocardial infarction or another type of angina called transmittal angina. Believe me, if you mention this to any clinical examiner, immediately you would score A++++. No more question. And he will recommend you, when you finish, please leave dentistry and come to the... But we will be a loser because they will take you. We teach you to be a dentist, to stay with them. Okay, So these are, remember, I am giving you a clinical orientation for the exam. When you mention, you always prepare yourself when you mention some finding, the examiner will ask you, what are the causes? Okay. Like this. If you find, for example, the rhythm is irregular, they will ask you, please mention a few causes of irregular rhythm. If there is ST segment elevation, can you mention to me some causes? Prepare yourself, Understand? Don't say, don't think like ST segment elevation. Oh, I'm very happy. They will catch you again. Few causes. Okay, The second, acute pericarditis. Acute pericarditis can lead to ST segment elevation. Okay. And now I ask you a question. How you differentiate acute pericarditis from myocardial infarction on the ECG? Both of them, they will give ST segment elevation. But there is one hint I mentioned already. Have answer? Yes. How you differentiate this? Because it is completely different in the management, right? Myocardial infarction, if you make a delay, the patient will die. They will die immediately in front of you. So myocardial infarction, you have to be very serious with this ST segment elevation. And ST segment elevation with a chest pain can be acute pericarditis. Any idea? Anyone can make me to fly? Myocardial infarction, this is for you. Myocardial infarction usually localized, right? There is no infarction of whole heart. All the heart infarcted means you will die on a time, right? Never happen. So usually infarction can involve some branch of the coronary artery localized area, right? So the finding of ST segment elevation will be localized to some leads in the ECG, right? But pericarditis is what? So very good, Naqi. Yes. So ST segment elevation in all leads. This is indicated with pericarditis. This is from a clinical practice. Okay? Are you okay now? Myocardial infarction. Still we are in myocardial infarction. Okay. Now look at this. Now the question, do you think this person is having myocardial infarction? Why? Everything is there in the slide. Huh? But I will make it a little bit interactive and let's show. Yes. Now, do you think? Yes, huh? Yes. Very good. Where is the, what is the evidence? One, two, three, a little bit three, yeah? So, what is the evidence? This is the location, but what is the evidence? ST, you have to say like this, ST, there is ST segment elevation, huh? In, okay, so this is very, very clear, huh? See other finding, huh? Look at the ECG in general. Look at this, see, what is this? What is this? T wave, huh? Inverted. This is called T wave inversion. Inverted, this is the opposite. This is the normal T wave. So inverted, right? Again, this is supporting for the diagnosis. Okay, so now in which leads? V1, V2, V1, V2. Okay. Other leads? There is any evidence of ST segment elevation? Lead 1, lead 2, lead 3, AVF, CAVL, depression, huh? ST depression, huh? So now, for you, you have to, not a depression, you are depressed, ST. ST, it is depressed, not you, huh? So, ST is depressed. Because the heart is not normal. Yeah. So now you're finding ST segment elevation in like this expressed like ST segment elevation in V1, V2, V3, indicating anterior wall myocardial infarction. Very excellent. Okay. So these are the findings. Okay, anterior myocardial infarction. Yeah. Okay, see? Intentionally I put this in. So from this we can proceed further, localize which artery like this. Huh? This is a significant. Okay, now look at this. Don't think they will give you sometimes a very beautiful ECG that clear pink in color. Very sharp. You're the hospital like this. Shivering, shivering. Any evidence of myocardial infarction? Or no? Yes? Just talk, please. Just speak with me. There is? Okay, there is. Where it is? What? Lead? 3. So what's the finding? The ST elevation, huh? See, yeah? Even it is one small square, right? It is not so clear, but it is significant. Accompanied by inverted T wave. So now there is evidence of myocardial ischemia or myocardial infarction in lead 3. Only or any other locations, any other leads? V5. We say V5. V5. This one, huh? You mean this one? Okay. It is not so clear. Huh? If you are not confident about this, look at lead before and lead. If there is no such finding, ignore it. Okay, yeah? So we have lead 3. Any other? AVF. Very good. AVF. So lead 3, AVF. What's the other lead which is related to these two? Lead 2. Lead 2. Huh? You can find something. Yeah. So now the finding is only 2, 3, and AVF. This is indicating what? Inferior. In the exam, they like to bring this inferior myocardial. So these are the findings, and this is inferior myocardial. Okay. Now look at this. What are the findings? Look at lead 1, huh? There is what? Same finding at AVL. And V2, V3, V4, V5, and V6. Huh? So, you are agree there is evidence of myocardial ischemia? Okay, so now 1 AVL and anterior chest leads and lateral also, right? So anterior and lateral. Okay. Yes, anterior and lateral. You find it easy, no? Easy myocardial infarction. But may Allah protect all of us. Okay? Now, look at this. What do you think? So when you try to conclude your finding, mention first the thing which is very clear for you. Okay, now please. Anyone? What's your finding? Regarding ischemia, what's your finding? Your finding? Ibn Sina.
Non-ST elevation.
What?
Non-ST elevation.
There is ST.
Non-ST elevation.
Again?
Non-ST elevation.
No ST elevation. Your finding is no ST elevation. Okay, others, please.
I think inferior
Inferior and lateral myocardial infarction. Okay, inferior based on what? It is based on this 2, 3 ABF. So you think this is ST elevation, huh? But Ibn Sina said there is no ST elevation. So you think this is ST elevation, right? Okay. So for Naqib, he said that there is inferior lateral, huh? Inferior lateral. So inferior leads 2, 3 ABF. Lateral leads from usually lateral leads V5, V6 mainly. So what is the V5, V6? This is the V5 and this is the V6. If you look at the V5, is there any ST elevation?
No.
V6 also there is no ST elevation, right?
No.
There is what? Depression. Depression also. If you look at other leads also, see here, see here. Look at this. And look at this. So this is elevation, this is depression, right? This is the mirror image. This is called a reciprocal changes in the ECG. Okay. Just focus on the clear finding. Huh? Other finding, it has an explanation, but I mean not everything I can. Otherwise you will be loaded. But the important thing is to recognize infarction, and it is very clear, and its location. It is more than enough and very excellent. So for us, the ST elevation is seen in 2, 3, and this is ST elevation. This is a and also it is called hyperacute ST elevation. Okay. When I see the patient in this with this picture, I know the MI not more than 4 hours from this picture. As I mentioned, the ECG is very beneficial. So this is an ST elevation. Please keep in mind, they may bring this one, like this picture. It's very clear, no doubt. So just you need to mention that there is ST elevation in lead 2, 3, ABF. If you like to proceed more and further, these leads indicating the inferior wall of the heart. So my conclusion is inferior myocardial infarction. Okay? There is also in lead 1 ST elevation, right? And lead 1 reflecting what? Is it anterior or lateral or what? Anterior? Lateral. So if these are more detailed, okay? I no need to go further. Okay, no need to work further conclusion. So it is inferior myocardial infarction, straightforward, like this. Are you okay with myocardial infarction? Can you recognize? Yes. Thank you very much. We skip many things. Huh? Okay. So now, you like to take the break, second break now? Okay, then we go to discuss some other things. So now, by this time, your approach to the ECG is to look at the rate, count the rate. Look at the rhythm, is it regular or not regular? There is evidence of myocardial ischemia or myocardial infarction or not. Don't miss this up. So now I spend 2 hours for this conclusion. After this break, we will go further, inshallah. Okay? To give some regarding the axis of the heart, also easy and common to be asked. Then the hypertrophy. Then I will cover some arrhythmias. Yes.
Doctor, if ST segment, ST elevation, it indicates myocardial infarction, right? If depression.
ST depression can indicate myocardial infarction. It is called subendocardial myocardial infarction. This is another type. That's why I'm not mentioning this. But she is a smart student. She likes more details. So we'll give more details. So ST depression, in the diagnosis, it is called, if the patient having this, we mentioned like the ST elevation, myocardial infarction. None ST elevation. We don't say that ST depression, myocardial infarction. No, it is not used in the clinic. So we use non-ST elevation, myocardial infarction. This is one cause. ST depression can be also due to electrolyte. Can be due to electrolyte disturbance. Sodium, potassium, calcium also can lead to changes in the ST segment. Yes?
And if we given the ECG paper and then there is a depression, so if the examiner asks if there is a myocardial infarction, so if there is depression, so we answer non-ST elevation.
Yeah, it may be, expressed like this. It may be because there are other causes. There is other causes. It may be non-ST elevation myocardial infarction. Okay, yeah. Okay, take a break now, please.
How about ischemic?
What?
How about ischemic?
Ischemic heart disease.
Ischemic heart disease.
With the relation of ST segment.
Ischemic heart disease, it is a broad name. Ischemic heart disease, it includes the acute coronary syndrome. I will give you the, otherwise this is very important. Any eraser? Eraser please? Okay, we use tissue. Okay, this is important for you to know. So ischemic heart disease, it is not specific name, just broad name. Ischemic heart disease. Ischemic heart disease. This one can be acute coronary syndrome. Okay, yeah? Acute coronary syndrome itself can be myocardial infarction and angina. Angina, we have different types. One of them is okay? So this is the acute coronary syndrome. Ischemic heart disease can be non-ST-MI. This is indicate there is ischemia. There is ischemia in the heart, but it is not to the power of the body. It can affect the mechanical function of the heart. But there is ischemia. There is some areas of the heart no enough blood perfusion. Okay, so the ischemic heart is very broad, very broad thing. Ischemic heart disease can be as a complication of any ventricular hypertrophy. Ventricular hypertrophy. Any ventricular hypertrophy can be associated with ischemic heart disease. So there is an evidence. You will show evidence of ischemia on ECG. Okay, so this is in general, but commonly focus on acute coronary syndrome, which can be myocardial infarction, can be angina. Okay, angina we have different types. Okay, take the break, please, Then we resume again.